Okay, hello and welcome everyone. In this video, I'm going to talk about some aspects pertaining to the hospital structure in the US system. I'm going to start off with a historical element, thinking about the Certificate of Need practice that had required and requires providers to get approval before expanding whatever are their facilities or capital that they're using to provide medical services. The idea was, well, let's avoid costly duplication of hospital services. Let's not pay for this large fixed expenditure here and here as well, and then siphon off the volume of patients necessary to support it. Instead, what they do is they require government approval for these expansion projects. And the goal was, well, to avoid wastefulness and to avoid duplication and these sorts of things. In practice, what happened? Well, it actually reduced competition and entry of HMOs and nursing homes into some markets. And actually, it probably introduced substantially more inefficiency, because here the approval for whatever is the capital expenditure is being driven by the government rather than driven by market forces. The market, assuming that you haven't got market failure, the price mechanism will tell you where the investments ought to be. Where are the lucrative projects? Where are the things that are warranted in a given population? And here we have laws regulating where the capital expansions can be, and certainly sort of counterbalancing any potential economic surplus that could be gained. Thinking about the U.S. institutional setting from the standpoint of hospitals, well, hospitals are super important in terms of institutions in providing healthcare in the U.S. We have a couple different several different categories. There's community hospitals, where you're thinking of sort of smaller, short-term duration stays, where you have a hospital that's providing a wide range of whatever healthcare needs that the population might have. Then you'd have more specialized hospitals corresponding to psychiatric services or addiction treatment or whatever is the case. Then there's physician-owned hospitals. So the idea here is you might have a physicians group that's grouping up and owning and operating whatever is the hospital and specializing in whatever it is that they're really good at. So it could be like a heart hospital or cancer hospital or whatever is the case. And then lastly, there's teaching hospitals, which would have some affiliation with a medical school and then host at least one medical residency. Thinking about hospitals and thinking about hospital compensation brings us right to the doorstep of thinking about the rules of Medicare and Medicaid. So it turns out the reimbursement rules for Medicare and Medicaid are really important for the financial stability of the hospital sector, because this is a main place where those patients are receiving their care. So it was reported, in the aggregate, Medicare paid 88.5% of the actual costs incurred by hospitals in 2014. Medicaid paid 90%. That's not 100%, right? So in addition to those underpayments, the hospitals are also providing billions of dollars in uncompensated care to the uninsured, right? What's happening to counterbalance this? Well, the patients that are covered by private insurance ended up paying something like 144% of actual costs incurred in treating them, which is called cost shifting. So on the one hand, this looks like you're having those who have a higher willingness to pay for those who have a lower willingness to pay, and that might be unsatisfactory. On the other hand, like in any other type of market, maybe this shows price discrimination, where you have those who have the higher willingness to pay and have the more inelastic demand are asked to pay a higher price, and those with the lower willingness to pay and the more elastic demand are given a discount so as to bring them into the system.